Hello, good afternoon. Can someone please confirm if you can hear me, please? Great. Um, so I'm going to go ahead and get started here. And what I'm going to is I'm going to go over one of the presentations that I made some time ago, and this is the one about the percentage based off the duodenal switch. And then there's a second presentation. We'll go in depth a little more about activity and exercise. There's also a couple of questions that I've been asked to address. And I apologize because I have split screen here. So if I look at, I'm looking at my right-hand side, I'm checking the questions that I've taken notes on to try to address. So I'll go ahead and get started. This is a presentation that I made some time ago about percentage-based bypass of the small bowel in the duodenal switch operation. And this seems to be a topic that keeps coming on and on and on again. I saw a patient today that had a sort of a standard type duodenal switch operation with a preset measurements of the weight. And then now we're talking about possibly revising it because looking at the operative report and based on the patient's height, I think that the patient has a common channel that's way too long for their metabolic state. And I'm going to go through these slides very quickly because we've talked about this in the past. Essentially, what we did many years ago, we presented our data that talked about how with the duodenal switch operation, we were measuring our common and alimentary limb based on a percentage of the total length versus a pre-measured, predetermined length. And the objective of our study was to say, can we accomplish two goals by giving the patients a percentage-based common and alimentary limb versus a standard length. And those two objectives were maximize the weight loss and minimizing the nutritional deficiencies that may follow if the common and alimentary limbs are too short, because those two expected results are interestingly in opposing direction. I can make someone's common channel very short, which will result in them having excellent weight loss, but really poor nutritional status. And if I was to avoid any nutritional deficiency, I can make their common channels longer, and those patients will not lose enough weight, and they will not have resolution of their comorbidities. In particular, a patient that, as I said a little earlier, who was able to get off of their diabetic medication for a short period of time, but the hemoglobin A1C slowly climbing, and the primary care is now talking about putting them out on some oral hypoglycemic agent. And the patient is here saying that I had my surgery a few years ago, I lost some weight, even though I never got too far down, and now what do I do about this? So with those two objectives, as I said, we've already been through these slides before previously. It's on our website as a webinar. There's one particular slide I want to get to that I added to was that those physicians that do the length of the common channel or alimentary limb based on a predetermined length of bowel are assuming that the length of the bowel correlates with the patient's weight. And in fact, the science of that is pointing away from the theory. There is no correlation between the size of the stomach and obesity. There's no correlation between the length of the small bowel and obesity. And in fact, as this graph shows, if you were just to look at the length of the bowel as measured in centimeter, you can see the dots are all over. When you plot that against different variables, the patient's height, patient's weight, the only, and this is age independent, the only thing that seems to fall into a pattern is a relatively broad-based linear regression that says the taller the patient, the more length of bowel they have. It doesn't say the heavier the patient, the more length of bowel they have. This only shows that the correlation that exists with, and this says it's a 95% confidence level, is between the bottom dash line to the top dash line. And if you were to, and I'm assuming you don't see my pointer, correct? Do not see my pointer. And so so what this graph shows is that the only correlation that exists is between the patient's height and the patient's length of the small bowel, which is why you really can't look at a patient's weight and say, because a patient has a BMI of 40 and they are, for example, 300 pounds, then they should have a shorter common channel, because if that patient is 6'2", then we're going to really mess up that patient's metabolic rate. Yet a patient that's BMI 40 and 300 pounds, and they have a certain height, if you were to keep the same BMI on a shorter patient, then you will not be giving them enough malabsorption to allow for the weight. I don't want to sort of dwell on this too much, but this presentation, this graph will be on our blog. The point to be made is that the scientific evidence only points to a relationship that exists between the patient's height and patient's length of the small bowel. There's no correlation between the patient's weight and patient's length of bowel, which is why I do not understand why certain practices will say, well, because you are heavy, I'm going to give you a certain amount of common channel. That really makes no sense. Those patients are either going to have too short of a common channel and have significant malnutrition, or they're not going to have they're not going to have a short enough bowel, and they're not going to lose enough weight. So if there's no question on this, I'm going to switch these slides and then go back to my next presentation, which is what we're going to talk about next. So I want to, this sort of looks like a very long presentation, but it's not. I've sort of tried to put a whole bunch of pictures in there to keep everyone awake and not fall asleep on me. But when we talk about weight loss surgery, we've always said that, obesity is essentially a disease condition that can be affected by a number of variables. Genetics plays a significant role into it. That may also include conditions that may affect our metabolic state, hormones, and so forth. Then there's also the diet and exercise component. Just as a reminder for everyone, when we make recommendations for the diet, we talk about water, protein, everything else, no artificial sweeteners, no carbonated drink, stay close to the dirt, and the Elmo diet. Water, protein, everything else, self-explanatory, no artificial sweeteners, no, Splenda, NutraSweet, and so forth. Stevia is good. Honey and natural sugar is good, but we just need moderation, clearly. No carbonated drink. The only thing worse than Coke is Diet Coke. And stay close to the dirt, which means that the less processed the food, the better it is for us overall. an ELMO diet, the ELMO, the ELMO from the Sesame Street, eat less more often. What we should do is eat frequent small meals rather than infrequent larger meals. So that sort of addresses the diet. Note that with the duodenal switch operation or practice, we don't tell patients what to eat, what not to eat, just make broad, healthier choices. And I'm going to use this podium again to raise my objection to some of the bizarre things that it's out there, this massive amount of fat consumption that is not healthy, any supplements, any of these non-scientific starvation modes, or forcing a patient to go into ketosis and so forth and so on. We just need to assume a healthy diet, and healthy would be what I described roughly in general terms. Then it also comes into exercising. And I really think we need to distinguish between what is defined as an exercising. It really makes no sense when we go through drive-thrus because we don't want to walk, and then we go to a gym to get on a treadmill to walk around. I mean, just sort of, it's counterintuitive how we try to minimize activity through our daily lifestyle, only to sort of punish ourselves by going to the gym. But as that may be, there are some of us that will benefit from that camaraderie and the sort of group mentality of being able to do things like this together. So let's talk about this in general forms and the benefits of the physical activity. It's physical well-being for all shapes and sizes. It's, we really don't want to aim as to having a target of, I want to really get to this size or this. We need to look at benefits of the physical activity as a lifelong, long-term plan versus a short-term sort of a punishment type of thing. As I said earlier, the elements of the weight loss are the genetics, and under genetics, it may be things like hormones, certain types of medication, depot shots, Norplans, certain antidepressant, some hormone infertility treatment in some patients, for example. All of these things can cause, under that umbrella of the genetics, can cause weight gain, and we need to account for that. On top of that, we want to be active, and how we need to eat healthy. Most effective in is when we incorporate all of those components. So weight control is most effective when it's used with conjunction in a reduced calorie diet. And in our cases, we're talking about surgical calorie restriction, whether it's with the duodenal switch that incorporates a reduced in volume, the hunger hormone ghrelin, and the malabsorptive component of the duodenal switch. And in some cases where the sleeve is, again, reduced stomach size and the ghrelin. And on top of that, a healthy activity level and healthier dietary choices are what ends up giving the best result. Let's just briefly talk about body composition and what we're made of, essentially. So we have the lean body mass, which is the muscles, and then we have the fatty tissues, and there's a most abundant component of our body, which is essentially the water. And then we also have a lot of other stuff that puts this muscle, the fat, and the water in different components. That may increase the bone that holds us together, so we're not a jellyfish. A connective tissue that holds all of our components together, the muscles and the tendons. And then you have the nerves that connect all of these tissues together in a functional forms. When we're thinking about body form, we think about shapes, the endoforms, endomorph, which are body morphology that tends to store the fat, mesoforms, which are muscular, and ectoforms that usually is of a subset of the mesoform, which is more of a thin muscular form. The common denominator of all of the energy restriction or reduced energy and superimposing that with increased activity has to do with the way our body handles the energy. So there are essentially three phases of the energy, and I'm going to sort of put this, we'll go to this slide and then go back for a sec, is that though, if you think about it, there's sort of levels of energy processing that our body uses. And there's this spurts of very rapid response, source of energy, the ATP cycle, where it's in a matter of seconds. So our body system that uses a certain types of nutrients that needs rapid response, nerve cells, heart muscles that contracts at a certain pace, our brain cells that need to function at a fast pace, blinking, processing of the vision, and so forth, reflexes, all use cells that are mostly on ATP cycle. They're like rapid response, high octane, if you would. And creatinine phosphate, they work in that 0 to 10 second time frame. Then you can have non-oxidative, which is essentially the muscle glucose glycogen that works between 10 minutes and 90 seconds. And then the next phase above that would be things that requires oxidative. So this is sort of the fat processing, carbohydrate breakdown, and protein processing, which is for slower, steady state endurance. Just to sort of put this in an analogy and for us to appreciate what this terminology means, is that if you have let's say 3 runners, and one of them is a sprinter, the other one does a 100 laps, and the other one is a marathon runners, those patients will use different types of nutrients in their body's muscle structure to be able to maintain their peak performance. A sprinter would require a lot of muscles that fire very fast so they can get to the finish line at the 100 meter they're running, and their build up and their way they process the muscle would be significantly different than a patient has run marathon, for example, that doesn't need that rapid firing. They just need to be in an oxidative state to be able to process these in a long term for the extent of the mile, but at the same time they need to be able to their body has to find a way to get rid of the body off of the byproducts that generate. So again, rehashing this again, the ATPs are short spurts responses. Then you get to the non-oxidative state, which is the middle column, and then the middle line, and then on the top one, the oxidative state, which sort of starts at about 60 seconds and goes for a longer period of time. The energy systems in our body are needed for a whole series of functions, things that are obvious that we need, walking around, running, playing, and so forth, playing sports, and also things that it may not be as obvious. Our body continuously burns energy in order for our livers to function, for kidneys to work, for our heart to pump, and for us to be able to breathe and talk and function. From a nerve structure point of view, there's 2 parallel systems. You can think about as the depressant and the stimulant type of a system. So there's a parasympathetic system and the sympathetic nervous system. The job of the parasympathetic nervous system is to slow the body down. And the parasympathetic nervous system, for example, vagus nerve is one of those nerves that has a lot of parasympathetic function. And on the left side of your image, when you're looking into your monitor, you can see the brain, the spinal cord, and there's this yellow cable that comes down with a whole bunch of green branches. If you follow those green branches, the middle, 1, 2, 3, 4, 5, 6, or 7 of them, they all go to the bronchi, the heart, the liver, the gallbladder, the stomach, and go all the way to the colon. And that's a branch of the vagus nerve. And the vagus nerve is a parasympathetic nerve whose job is to essentially regulate the heart rate, control the secretion of the bile from the gallbladder and the liver, emptying the stomach and the pyloric valve, and so forth. On the opposite side, we have the sympathetic ganglion, which is sort of the sympathetic chain of a whole bunch of relay stations, if you would, that starts from the spinal cord. And the job of that is to essentially speed up the body. From an evolutionary perspective, when we look at the parasympathetic and the sympathetic nerve, if I am an animal in a jungle and I suddenly see a predator, the first thing that happens, my heart starts racing, and I start sweating, and I get nervous, and I start run around because I need to run away from the predator. So all of those signals are released and are managed through the through the sympathetic ganglion. And you can see on your monitor's right-hand side, there's a spinal cord, and there's a chain of those little dots, and the yellow dots that connect to the nerves, to the branchia, to the trachea and the heart, and through those systems is what allows us to regulate. So why are we talking about this when we're talking about exercising and weight? Is because if we can, through certain activity level, stimulate our sympathetic nervous system, we should be able to drive our energy expenditure up, which is sort of the long-term benefit of being active and being healthy versus being sedentary and inactive, which may be more of a parasympathetic pathway. So it is, I've said this repeatedly in the office when I've seen patients, that it is very important to look at activity as a more of a lifestyle rather than a punishment that, hey, I got to do this again type of a thing. I think if we need to look at this as a broad approach to how can I be active throughout my life, taking the longer walk with the dog, going around the block to pick up the mail, taking the stroll to the grocery store versus driving down, parking the car instead of going through the drive-through. All of those things needs to be incorporated into our lifestyle. The physical health, from a personal point of view, it is part of our overall health. We need to be physically healthy, way above and beyond just having a normal blood pressure. Our attitude, exercising, active living, and nutrition are our components. And one of the things that we rarely talk about, because it's sometimes we feel like we have no control over it, is stress management. At times when it seems like we cannot control the stress directly, we can try to control the effects of the stress on our health, and that will be by trying to disconnecting ourselves and getting to do something such as exercising, hiking, biking, running, and so forth and so on, to try to alleviate some of the physiological effects of the stress, which may be parasympathetic in a sense, indirect increasing blood pressure, heart rate, and so forth. And exercising by itself, even though on a short term may up our parasympathetic sympathetic stimulation, and that's why the weight loss, for example, or stabilizing the weight loss, overall it allows us to de-stress and turns things for the better. Lifestyle is your responsibility. It's all of our responsibility. It's very important to appreciate that the triad of the genetics, which is addressed by weight loss surgery, and diet and activity go hand in hand. When it comes to diet and activity, we are essentially going to pay the consequences of the choices we make. That may be food, activity, and as I said, the stress is something that it's overlooked most of the time and really can't do anything about it. What do we need to do today is to think about all of the actions that we take in our life has short-term and long-term consequences. Being active, it's very important to think about osteoporosis, for example, as one of those long-term issues, that when I'm active, I'm not only addressing my health immediately short-term because now I burned off that extra Big Mac or fries that I had, but I'm also working up my bones that will provide for a long-term healthy bone for me for the years to come to avoid osteoporosis. These are things that we may not see the effect of it immediately, but it needs to be done for a long-term effect of it. Osteoporosis, diabetes has been shown over and over again for the patients that have had weight loss surgery and or those patients that have not had weight loss surgery. Blood sugar control is much easier in a very active, healthier patient, diabetic, or patients that are not diabetic anymore because they've had weight loss surgery. We've all heard also about the fact that, heart disease, stroke, obesity by itself, stress, and on and on and on. The punchline would be that the effect of leading a very active lifestyle goes way past and beyond the immediate, energy expenditure, and it has long-term consequences for all of us. Risk of the coronary heart disease is significantly depressed. Hypertension is lowered, the blood pressure can be controlled, the blood lipid disorder, cardiac function, smoking reduction, weight management, diabetes and musculoskeletal disorder, as well as stress management and bone mineral status. These are all of the sort of benefits in the short to intermediate form. Just as a side note, and I probably should have put that here, but I didn't. There was just a recent study, I don't know where I saw it, it was a recent journal, that showed that this whole concept of the HDL, the high density lipoprotein, being beneficial in patients has been shown to not necessarily be true in patients that have overall high lipid levels. So when we look at labs and we say, well, your cholesterol is a little high, but it's good that your HDL is high, that has proven not to be accurate because there's a lot of discrepancy, and the patient's cholesterol needs to be low and the HDL proportional to that needs to be high. Now, I probably should put something right there at the separate blog to make that clear a little. Overcoming inactivity, it's sort of interesting because we all find this is that we have a much harder time starting exercising versus continuing to exercising. And there's some physical phenomena maybe into this. One of them is called inertia, that a body likes to keep its position, whether it's moving or stationary, at that state. So if it takes more energy for us to move than to keep moving. And patients that tend to be more mobile throughout their activity, throughout their job, because of what they do, tend to be a little easier for them to get into the routine of exercising versus patients that tend to be immobile, which sort of may not be the best thing, because if a patient is relatively immobile, can benefit more from activity than a patient that usually moves. So keep moving, be more active. We should make this fun. And if possible, group activities, sort of the group mentality, that's probably one of the few benefits of joining a gym versus and having someone to go along with you, which is the benefit of having someone to have a group mentality versus to sort of feel like I got to do this by myself. It also allows you to have a support system to sort of be your cheerleader, and you can be their cheerleader and have a lifelong support on that. Reasons to exercise and other consideration: the health benefits, the fun, social accomplishment, energy, self-esteem, body image, stress management, and lifelong participation. And some other things that may or may not be, and I sort of took this down from a paper that was talking about how to try to entice patients to get them excited about this, would be to make the points of the drive for be thinness. If a patient has to another 10, 15 pounds to lose, why can't we encourage them to go and exercise? Drive for muscularity. This is, I guess, for men. If a patient has a certain obsession with certain things, if we can find a way to channel that obsession into going to the gym, it may be a good thing. We want to avoid patients that are only concerned about the body image. This needs to be presented into a healthy approach. It is important for patients to also appreciate that when a patient, when someone is taking on a very active exercise plan, part of that activity needs to be offset by accounting for the extra protein that we need. So it is not a good idea to force a diet by calorie restriction while at the same time picking up an exercise plan. That sort of essentially puts our equilibrium of the energy and nutritional balances off kill. So we need to be active, and we need to be able to eat healthy with the micro and macronutrients to support that high level of activity to be able to build muscles and be healthy. The principles of the training. Now, I'm not a physical therapist, so I've tried to do the best I could to sort of put things together. It is important that we appreciate that each one of us will have our individual workout plan that will work best for us. It needs to be individual. It needs to be specific. We need to progressively overload this, and I'll talk about that a little later. Every one of us, when we pick up an activity level, whether that's going to the gym 5 times a week or that's picking up hiking or biking or running, we need to have very realistic plan with us that we're gonna, the first day I'm gonna go, half of the block. The second week I'm gonna go two times around the block, And if I need to, I may have to stay there for a little while because I've hit a plateau and I need to build my endurance before I can go to the next step. There should not be these exercise plans, whether it's individualized or in a gym, is not a competition between anyone. The only one that we're competing against is ourselves, and we need to move our own targets further out. We're not competing with anyone else. So in a group environment, it's important to have that realistic expectation. It is also important to have a balanced exercise. A lot of our patients will have specific joint issues. My knees hurt, my back hurts, my heels hurt, my shoulders hurt. You can't really expect a patient who has bad shoulders to be able to do a lot of heavy weightlifting, but they may be able to do very well with some abdominal workout. A patient that has had major abdominal surgeries or has a pre-existing hernia or what have you should still be able to get to a gym and do isolated arm muscles, do some lifting and pulling and pushing of the legs with machines or some low weights without really crunching the abdomen and increasing the abdominal pressure. So all of these things need to be individualized. We're talking about aerobic training. There's the acronym FIT, F-I-T-T, the frequency, 3 to 5 times per week, intensity, about 50 to 85% of the predicted heart rate, and we'll talk about that. Should have this thing for about 20 to 60 minutes, and the type of the mode would be walking, running, swimming, and cycling. So, if you really want to do an aerobic training, I should get out 2 to 5 times a week, walk for about half an hour or so, walk briskly to increase my heart rate to about 50% of my predicted heart rate. I'll skip this for right now. I may have to come back. As to how do I measure my target heart rate, as I said, we'll put this on our website, so those of you that want to look at this can be able to look at it. The target heart rate is your heart rate maximum minus your age, so 220 minus your age, and this is sort of a rough guesstimation. And so what you do is that 220 minus your age give you a target heart rate per age, and if you want to maintain that between 50 to 80% of that, you just point 50 to 80% of your maximum heart rate. You sort of do the math, and that sort of gives you a range. So I can do the math, and on this table, so on that intensity of 50 to 80% of the heart rate, so it'd be 220 minus my age, and I take half of that, and that gives me about 50%, so I bump that up. So I need to be walking fast enough to get my heart rate high enough. So here's a disclaimer that if you have any chest pain or shortness of breath, especially chest pain with this, please don't do this, because I said on a webinar, see your primary care. You need to probably have a cardiac workup before you push your heart to a range and get yourself into trouble. We'll talk about this later. The key with the heart rate is that it drives the blood flow through our system, and that sort of ends up being where the exchange of the nutrients and oxygen and the energy takes place. Just briefly about the heart, it's the size of our fist. It pumps about 5 liters of blood each minute. It has 4 chambers, 2 on the left, 2 on the right, and the heart rate, the beats per minute, is sort of the RPM of the heart, if you would, and the higher you pump, the more liters of blood you process through the system. It is intensity dependent, so if you remember on the slide, parasympathetic and sympathetic, both of them control our heart. If a patient has overwhelming parasympathetic stimulation, vagus nerve, for example, some people have talked about the dumping syndrome and so forth and so on, or the syncope, they're all modulated through the parasympathetics and the vagus nerve. Then that is offset by the sympathetic, where the fight or flight fear comes in. As I said, if I'm an animal in a jungle and I see a predator, my sympathetics will kick in and drive my heart rate up. We want to appreciate that there is a maximum amount of cardiac output, how efficient the heart is, and that's dependent at a maximum heart rate. So if my heart is pumping at a certain amount of rate at certain RPM, you can't get any more out of the heart by pumping it even faster. And that's the discussion, that's sort of the point of being sub-maximum versus maximum heart rate, whereas we all have a resting heart rate that stays. Just as a side note here, it's been observation made, and we've seen this all the time, is that on an overweight patient, when they lose the weight, their heart rate would naturally come down. That's because their heart rate has been so efficient for so long, pumping against a high volume of resistance as an excess weight. It gets easier for them to pump when a patient has lost 200 pounds. So it doesn't need to pump a lot of volume very fast. It can just pump very slow. And because the resistance of the weight has gone away, they're efficient enough to be able to pump the fluid through. The heart calculation, cardiac output, heart rate, and predicted heart rate on the lower end is about 60%. On the higher end would be 90%. Again, different numbers from different websites. And the maximum heart rate should be 220 minus your age. The other part of this equation is the lungs. Anatomy of the lungs starts at the vocal cords, below the vocal cords, that the air goes into the main the trachea, and the left or right may bronchi, and then divides into further. That's where the oxygen and CO2 exchange takes place. The room air, I guess clean California-based air, is supposed to have 79% nitrogen, 21% oxygen, some carbon dioxide. And the mechanics of the breathing is as such that we use muscle and energy to breathe. And our lungs function by the means of expanding our chest wall, creating a suction between the chest wall and the lungs that pulls the lung apart and creates a vacuum in the lungs, so the air rushes in from the ambient air around us through the oropharynx into the lungs. And the way we exhale is we relax those muscles, we allow the recoil of the chest wall back onto the lung, increases the pressure around the lung, pushes the lungs in, and the air comes out. The exchange of the oxygen and the carbon dioxide takes place at the cellular level, on the periphery, on the bottom of the image, and on the lung on the top. So in the lung, we exchange the carbon dioxide with the oxygen. We blow off the CO2 and absorb the oxygen. Then that blood is pumped through the left heart into the right heart at the tissue level. And then in the tissue, we absorb the carbon dioxide and unload the oxygen, and that cycle continues. And the efficiency of those skills will depend as to how efficient on heart and lung is, how fit we are to be able to be active. Strength and endurance training, unlike the aerobic training, it has a little different path to this. The frequency should be 1 to 3 times per week. Endurance would be, for strength, would be 1 to 3 times per week. For endurance, would be 3 to 5 times per week. Excuse me. For the strength, for example, for the intensity, strength, we want to leave 4 to 8 repetitions. And the key would be to build this up slowly, where we are doing about 50 to 80% of our maximum lifting of whatever, whether this is a machine on a that is one of those big fancy machines that's connected to cables and pulleys, and there's certain weight you can move. You want to sort of aim not for the 100% of what you can move, but about half to about 3/4 of that what you can move comfortably. And the key would be to do this repetitively to build up the muscle mass. The endurance would be to do it a lot more frequently with a lot less weight. If I can move, if I can move, 100-pound weight one time, what I really want to do would be to move 25 pounds 15 to 30 times. And if you're ever wondering, I don't think I can move 100 pounds of anything. For the bones, which is the other part of it. So we've covered the heart, the lung, and now, sort of briefly talk about the muscles, and now talking about the bones. The bones probably benefit least short-term, most long-term from an activity, other than the obvious effect of you need to have sort of fairly reasonable bone to be able to maintain this level of activity. the bone buildup and breakdown really occurs on a long-term basis with healthy vitamin D level, healthy calcium level, adequate level of protein, zinc, magnesium, all of that stuff. We've talked about it. The bones function for locomotion, for walking, for manipulation, for us to protect the organs. Our heart and the lungs are protected by the rib cage. Our brain is protected by our skull. And it also is a very large storage mechanism within the large bones. The bone marrow is where the hemostatic properties of the bone, where the bone, the blood production, platelet production, and white cell production takes place. And it's also a support mechanism of our endoskeleton. If you take our bones out, we'll be this big ball of jelly of the heart and the lungs and things like that that can protect or function themselves. They'll collapse on each other. The movement will be when we're talking about muscle movements, it's there's a couple of phases to this, and what we need to appreciate is that for us to benefit from fully from a weightlifting or any strenuous activity that stresses our bones and the muscles, we need to go through the full range of the muscle activity. That'll be the concentric, the sort of the positive, and the eccentric, the negative phase of this. I think I have left this, I took that slide out, but I had a slide here that talked about the molecular basis of how the muscles sort of contract and relax. The muscles essentially use energy for relaxation more so than for contraction. The way our muscles contract is essentially like a ratchet that's by default wants to pull things in, and our muscles have to spend energy to unlike those joints to allow it to relax. So you actually spend some energy pulling the muscle in and some energy pulling the muscle out and relaxing, and you can utilize both of those on the same muscle, other than the fact that you actually use the opposite side of the muscle to try to be able to pull and push. So the key from this slide is that continuous repetition of a low weight muscle is probably as productive, if not more productive long term for most of us, if it's for us to become healthy. The type of target muscle groups, we need to select appropriate for our health and weight and be able to balance this with different muscle group. As I said a little earlier, very frequently we'll have patients that they cannot get into a machine because of their back pain, knee pain, and so forth. And a very good compromise would be to get in the pool and do activities in the pool where you can walk and run and exercise against the resistance of the water, and that'll be enough to allow us to accommodate and become, build some muscles. There's water-based weight that we can use and so forth to burn some muscle, burn some energy by building some muscles. Time, we need to allow our body to adapt. As I said a little earlier, it's very important that we start this exercise in a form of a set plans. I start working a short spurts repetitively and build on that. And if at some point I need to wait till I recover from this, and I wait and recover from this, and then sort of build on it again. It's very important to, whether we're doing a very strenuous activity or we're training to do a lot of weightlifting for muscle, and or we're training to run marathon, to appreciate that during the workout phase, and this can happen during the same session or throughout the term of the weeks or months, is that we need to build on the steps one step at a time. No one will be able to get out, no matter how fit we were in the past, to be able to run from getting out of the house and run for a marathon. But what we need to do is we need to walk and run slowly, and then when we hit a certain target of comfort or whatever the measure may be, stay there till we've stabilized, and then overload that to the next step. And this overloading is when we're sort of building on our last plateau level of being able to go back on top of that. Again, this particular graph talks about the weight training, but the same model applies for all of the other training modules. we need to find something that works for us. Again, I'm not an advocate of going to the gym because I sort of personally have a hard time uh, doing that, but I think we can all find something that makes us active. It's interesting how when I'm preparing these talks, it seems like, I can talk about this with my patients on a daily basis. It is very important for us to find something that we like. Patients that say they sort of have found hiking to be very they didn't consider that they would like hiking, but now that's their way of doing, versus someone that's picked up the tennis after many years. Do what you like and be repetitive. We need to also have realistic expectation. We're not looking for a buffed modeling competition. The purpose of this is to be healthy. The principle of exercise is there's limitations to all of the activities that we do. These limitations may be individual for each one of us individually, and or it may be limitations to the nature of the training. Aerobic activity versus strength and endurance flexibility versus anaerobic training, they have different objectives and different limitations. Some of the basic things would also be needless to say. Just, as I said, while putting this talk together, it's important that we have the correct shoes. Being overweight over a long period of time will collapse the arch of the foot, and not very frequently, not uncommon, where we see patients that have significant amount of flat foot contour, and it's very hard for them to function because they'll develop heel ulcers, heel spurs, and so forth. So good pair of it doesn't have to be expensive. Good pair of shoes that has good arch support is important. Wear proper clothes and also stay hydrated very well. Patients do get dehydrated during exercise, and one of the things when I was putting this talk together is those wrap things that are supposed to sweat you off is really not recommended from a weight loss. I'm not sure what they do other than dehydrate you. They're essentially, it's like, cooking you in a sense and try to have you sweat the extra weight off, but now you're dehydrated, increase your chance of kidney stones, deep vein thrombosis, and sort of it makes no sense from a health point of view. It's important to also set the objectives clearly, start at a level suited for you, ask for help and exercise professionally. It is okay to miss a session. Very frequently, it's interesting how I've heard this many often, that I was going to the gym, I had my routine, then my car broke down there for a week. I couldn't get to work because, or I had a sick child and I couldn't do this, or something happened at work. And it seems like once I'm off of my routine, I completely give up. It doesn't have to be like that. We need to look at this as continuously. It is also important to appreciate that when we get into a rigorous activity, whether it's a formal exercise in a gym or it's a healthier activity level, our scales, the weight loss will slow down significantly, and in some cases will plateau and stop for a much longer period in time, which is actually very counterintuitive from a activity point of view. That's when patients will go back and say, when I measure myself, I see that my shape is changing, but the scale isn't moving. At a very simplified, primitive level, what's happening is that though I'm taking the extra energy, burning them off, but because I'm more active, I'm making muscle, which makes me have to stay tight. It is important to bear that in mind and not get discouraged whether the scale is moving or not. Stay hydrated, get enough rest, and eat healthy. As we talked about, a restricted diet should not be a part of a healthy lifestyle. It should not be a part of an aggressive exercise plan. We do need the protein, the hydration, the micro and macronutrients to be active, to be able to maintain a healthy lifestyle. Set your goals objectively. We need to, from the get-go, we want to set our objective. Why am I doing this? Again, there doesn't have to be anything particular. It's also important to sort of consider our individual body's nature and activities that we're choosing. Someone that has bad knees, is probably not a good idea for them to pick up Stairmasters on bikes. And a patient with a bad history of shoulder surgery because of rotator cuff should probably not do any weightlifting, for example. The muscles contract all or nothing. There's been some cases of a muscle injury where when a muscle is brought up halfway with the jerky movement to overcome the extra weight, you may have a tendon or a muscle injury. So it's better to go on a lower weight and pull them all the way. Work reciprocity. What you want to do is that essentially work on tandem by stretching and relaxing opposite muscles, adapt to the stress. It is important to also not build up a muscle by straining something. This is frequently seen in patients that do upper extremity or chest or pec exercises and throw their backs out. That's because they did not have the proper support of the back, or they were leaning forward trying to lift weight or something like that that stressed their back. From a muscle point of view, also there's two types of muscles. Three types. The cardiac muscle, it's sort of by itself because it essentially has one type of one place that you find it. But the smooth muscles and the skeletal muscles. Skeletal muscles is what it says. The skeletal muscles is what we use to move our bones, and they're essentially all of the big muscles that are on our face, body, chest, and legs that moves us around. And then we also have actually smooth muscles. The smooth muscles are the muscles that are found within the walls of the blood vessels and our GI tract. And that's the muscle that allows the food to be pushed down the esophagus into the stomach, where the stomach squeezes and gets into small bowel and pushes out for us to have a bowel movement. Improving muscle strength and endurance. The muscle strength, the amount of force that a muscle is capable of exerting, it's sort of 1 repetition maximum. And the key with this is that the muscles, you get different benefits from a repetition point of view, from exercising versus doing one time by lifting a lot of weight. For the purpose of health, energy expenditure, and everything that we've talked about, we should really be moving 5-pound weight 10 times versus moving a 50-pound weight just once. We want a small repetitive motions, whether that's a 2-pound weight, put in one arm and go around the block with the dog to pick up the mail, and while you're walking around, move that 2-pound weight in one arm and then 20 times on the other arm and come back and do it. That's sort of type of an activity that I want to pick up. Principles of the strength development is to increase the tension principle, which is increase the muscle tension and increasing the strength gain. The weightlifting is one method, and as I said a little earlier, those machines that have the pulleys and the cables and are all the other one. Riding a bicycle is also a good and healthy way to exercise. Just be mindful of a couple of things. Riding a bicycle, you have to watch your back. Number 2, the conversion rate for biking versus a similar path, walking briskly or running, is about 6-to-1, 7-to-1, 8-to-1 ratio. So if I was to bike a mile, or run a mile, I have to bike 8 miles, give or take, sort of a similar path to get the same energy expenditure, because of the fact that biking may be somewhat easier from the mechanics of the chains and the pulleys, so forth. Resistance exercise program, it should be part of a fitness program to improve muscle strength and endurance. And the purpose of this is hypertrophy, which is building the muscle bulk. You get this by doing significant amount of repetition over a long period of time with very large weights. So this would be doing a very heavy weight for a number of times over a matter of weeks and months at a time. It is also very important to appreciate that this hypertrophy of the muscle, the bulking of the muscle, does not occur in the vacuum. And it is very important to do that while you're maintaining a relatively high protein intake along with the calcium and other stuff that we need to. The muscle the muscle actions. There is from a physiologic and biologic point of view, and maybe some of this is a little too technical. There's the isometric muscle action, which is the force without movement, and I'll talk about this. The sort of when you if I was to pick up 50 pounds and I cannot fill up the 50 pounds, if I exert my muscle on it, my muscles tighten up, but the weight isn't moving. So that's an isometric muscle action, which means that my muscle is contracting, but I don't have enough force to be able to move that. So that sort of is still some sort of an exercise, even though visually you don't see the weight move. So it may not act like I'm doing anything, but I'm actually able to move the muscle to cause it to contract and burn the energy. Then there's isotonic muscle action, which is a force with the movement, and this may be concentric, eccentric, and the best result is for combination. Let's talk about what those may be in a sec here. Muscle of the methods of providing resistance, body weight resistance. These are sit-up, push-ups, pull-ups. Both are concentric and eccentric, which is, we're moving the muscles without really moving our body, with our moving position and moving any weight. So essentially moving the body against its own weight as a resistance. Then a fixed resistance would be a sort of constant absolute resistance, which would be barbells, dumbbells, where you're sort of moving against it, versus the biomechanics of joint angle and applied force when you use those in pulleys and weights and cables that can change. And one of the things interesting enough is that I'm maybe getting too technical about it. When you move a 5 pound or 10 pound weight with a dumbbell, that 5 pound weight throughout the entire muscle motion does not change. It's still 5 pound based on this. But there's some physics that it's been shown that based on the pulleys, when you're moving the pulley back and forth, based on the mechanics of the pulley, you actually have more force that you have to exert to start that pulling back of the pulleys to move that weight bar up and down on the bars than it does towards the last end of it. May not be much, but it's worth mentioning. Methods of providing resistance. There is variable resistance, analysis type of them. It distributes the load to the muscles so that each angle and the load angle is lifted, and accommodation is resistance to the change in response of the force, so speed is kept intact. So again, as I talked about, when you pull the pulleys, you exert more work and force to start it than to keep it going. Whereas if you have one of those exercise machines that have coils on them, or they have the resistance rubber bands, the amount of force that you keep on it is constant throughout the full range of the motion. So it is also, again, as I said, important. I have to keep repeating this again because there's in general, we may be told that, in order to maximize your weight loss, go on a diet and exercise, and that may not necessarily be the healthiest thing to do from the perspective of being able to keep my nutrition up, keep my water and protein up in order to lose the weight. We're not doing this just for losing the weight. We're doing this for all of the reasons that we mentioned, including being healthy, stress management, the bone and all of the other stuff that goes with it. And for that, we need to have a healthy nutritional state. Be kind to your bodies, warm up the activity, increase your body's temperature, heart rate, metabolic pathways, etc. So if you remember that those pathways, the first pathway, the sort of the ATP, the non-oxidative and oxidative, when you start running immediately and we're not prepared for body to warm up and get the heart rate up to get the oxidative products out, we get the Charlie horse in the muscles and make a muscle injury and things like that. So we need to sort of get ourselves ready. Improve the muscle performance by stretching so we avoid tendon injuries. Specific appropriate stretching is important for different muscles. You'll see runners that stretch their calf muscles and hamstrings and so forth to avoid any injury long term. The same conditioning also needs to be in a form of a cardiovascular conditioning. There's exercise-induced asthma that's worth mentioning for overweight patients. These patients need to be really careful. because of the nature of the disease, asthma can actually be exacerbated by the sympathetic, which what happens when you increase your heart rate, the fight or flight pathway type of thing, and that may cause me to have exacerbation of my asthma. So these are things that individually we need to also consult our primary cares or physician who's recommending this sort of strenuous activity level. So this is on the ramp up type, ramp up time, and then same thing happens also on the cool down time. You do not want to get out of a gym or a hiking or a running or a biking exercise and immediately sit down and stop doing anything. You really want to sort of slow down, let the byproduct of the oxidative state, which has now taken over, to be continuously flushed through our system. So we need to keep walking slower, slower heart rate down over time to allow for all of that byproduct and the toxins to get circulated to our lungs, to muscles, to kidneys, to get washed out. And that's sort of that heart end. And on the intake side would be to not forget to keep hydrating with not distilled water, which is sort of, I've already said this, sort of distilled water doesn't really make a lot of sense from a nutritional point of view, but also supplementing the salts and the macro and micronutrients in the form of a sodium, potassium, chloride, and magnesium, and so forth. This should be an active life plan from a life start. Are you ready to start a program? Should ask yourself health, injuries, attitude, reason to the exercise. And exercising can be defined as anything you like to. I guess having the remote control is also an exercise plan. But if we're going to do that, then I would recommend we all watch TV standing up all the time, not sit down at least. Resistance training, weight training, body as resistance. And that's instead of doing any weight or gym, we can do a lot of abdominal crunches, pull-up, push-ups, again within the limitation of the mechanics of the injuries. I have bad shoulder, I can't do any pull-up and push-ups. I have lower back pain, I can't do sit-ups, and so forth. This should also include a whole bunch of warm-up on the front end and the cooling down on the back end. Thank you. I know I went through this relatively quickly. I don't know if there's any questions. I know there's a couple of things that came up here. So there was a question that was asked a little earlier. One of them was about the stricture that happens, that people have talked about. Stricture is essentially a narrowing that may be most probably caused by surgery, maybe caused by scarring from outside, or internally may be caused by an ulcer that causes scarring outside. And a stricture, depending on where it is, more often than not will be required to be looked at by a surgeon. I have seen cases where a patient that had a stricture following a sleeve that was recommended, that was sent to a gastroenterologist who repeatedly did balloon dilatation to no avail. Those things are not going to get resolved by balloon dilatation. So if the patient has a stricture from a duodenal switch or a sleeve, my recommendation would be for them to see the surgeon. And clearly, if they're my patients, I want them to come and see me, not be addressed by a gastroenterologist, because not all of the strictures that are surgically that follow a surgery, not necessarily caused by surgery, but they're after a surgery, may not be amendable to balloon dilatation and something like that. There is another question that was talking about energy level after duodenal switch operation, and I guess if I have had the duodenal switch operation, I'm exhausted. What do I do? So I guess depending on what the time frame would be. It is not too uncommon for patients after duodenal switch operation to come back, in the first year or so, say, sometimes I feel myself, I find myself exhausted. When I get home from work, I just want to lay down and go to sleep. I really don't want to do anything anymore. So my answer would be, first and foremost, am I hydrated enough? How are my protein numbers? And if those two numbers are okay, and I'm sort of eating and drinking healthy, and there's no, there's no thyroid issue, and there's nothing else, we also have to account for, the fact that we may be 1 year or 10 or 12 years older than when we had the duodenal switch, number one. And the other thing that we don't pay attention too much is that, though, am I doing more or less than I was doing before? If I was 400 pounds, now 500 pounds 5 years ago, and I've lost down to 250, and I'm doing 10 times more, it is expected for me to be a little more tired. I'm not saying that's the cause, but those are things that I have to look for. So my first answer would be, so the things to look for if I'm a post-DS patient, I find myself very fatigued and tired, would be, number one, are my nutritional markers are in place, my protein level, calcium, vitamin D level, water, hydration level. If all of those things are normal, then I'll also want to at the same time look at my other variables that may be causing these hormones, whether it be thyroid, menopause, and so forth. Then would be, am I active or not? And then, the aging, as I said, I'm not sure if that may be what the time frame would be, but there's a number of things. I'm not sure if there's any particular study that says, patients are significantly tired after weight loss surgery, after DS for a particular period of time. In our opinion, patients that are tested for blood work and they're tired, interestingly, over a long period of time, not immediately after weight surgery, long period of time that we've not seen, and they sort of show up 5-10 years later, will be found to be a little anemic. So that's also a variable that you have to look at. So nutritional markers, hydration, hormones, and then activity. I guess those would be the answer. As far as the vitamin D injections are concerned, I mean, I've been asked that to comment on this. I don't know if I have a magical number for a vitamin D, whether I would administer a vitamin D level at a certain vitamin D injection at a certain vitamin D level. I would administer vitamin D to anyone that has a elevated PTH. The objective of vitamin D injections is to, number one, normalize the PTH level, number two, improve the calcium level concurrently with the vitamin D. I think vitamin D injections should be dictated based on what the PTH is, as much, if not more, than what the vitamin D level is. So if a patient comes to our office and they have an elevated PTH level and their vitamin D is still in 60s and 70s, I would go ahead and give them a vitamin D shot. I don't know, last week or a week before, I had a patient come to the office for follow-up, and their vitamin D level was, 112 or something like that, and they had gotten this alarming call from the primary care physician, rightfully so, to warn them of their extremely high vitamin D level, and they really need to avoid all of that stuff. And when we reviewed the lab work, I recommended that the patient stay on the same regimen that he was on, because after about a year of, this patient had sort of vanished into thin air and then show up many years later, showed up with a vitamin D level of, I think, 20s and 30s, and the PTH was in 600, and it took 3 injections, if I remember correctly, over that year frame, and 100,000 unit of vitamin D orally to drop the PTH from 600 to 200. So my recommendation to that patient was to continue going with the supplementation at 100,000 unit, even though we knew that the vitamin D level was out above the reference range. But it was important to drive the PTH down to normal before we did anything else. So if a patient's PTH is in 50 and their vitamin D level is 60, whether they should get a vitamin D shot, I guess my question would be, what is the PTH before this 50 level? If it was coming down and the calcium level is normal, then I would say no, I would stay. But if PTH is going up the wrong way, then I guess vitamin D would be a good in order, because clearly the PTH is going up, which means that the vitamin D and the calcium, even though vitamin D is sort of in the mid-normal range, it may not be enough to control the PTH. You are welcome. Any other questions? So another private question about SIPS and SADI. Let the record show my position on the SIPS and SADI is that I think these procedures are an unproven territory. It is my expectation would be that the patients with SIPS and SADI would have inadequate weight loss. That's just because you not only do not have short common channel enough, you also have your alimentary and the common channel in the SIPS and SADI procedure are of the same length. Unlike the duodenal switch operation, where the alimentary limb is 30-40% or 3 times longer than the common channel, in the duodenal switch operation, you have the distinction between alimentary common channel. In the SADI and SIPS procedure, your alimentary and the common channel lengths are the same, and so your fat, carbohydrate, and protein is the same. My expectation and my prediction is that the patients that have the SIPS and SADI will not have adequate weight loss, and they'll have to have this revised. And from a purely anatomical perspective, revision of a SIPS and SADI may not be as precise as it would be if a primary duodenal switch was done. And this has to do with the fact that because of the anatomy, the way it works is you may not be able to bring the alimentary, to transect the duodenum past pylori to bring it down far enough to create the same measurement and precisely the anatomical presentation of the duodenal switch. So a SIPS and SADI revision to the DS may on an operative report look the same, but it may not necessarily be the same as if you had done the duodenal switch. So why would the vitamin K drop? Vitamin K may drop because of inadequate absorption, whether that particular band is being absorbed or not. It also, vitamin K absorption may be also sensitive to the gut bacteria. So one has to consider whether there's a carbohydrate issues, whether there is probiotic issues or something like that. I don't think there is any particular difference in type of the exercise that has to be limited to because of the stomach surgery. I guess once anatomically I've healed from surgery, then I should be able to resume any or start any activity level that I like to. One of the other thing that that vitamin K absorption is dependent on is also fiber intake. So high fiber intake will limit vitamin K absorption. Any other questions? Well, If there is none, then I thank you, everyone. You have a good evening, and we will post this shortly. You're all welcome.